Welcome to everybody who's reaching us on this international webinar on Dental Tribune International. It is for me a pleasure to say buongiorno from Italy to all the Europeans, Americans, and Asians colleagues that are in contact with us today. So first of all, I would like to thank the Director Dental Group on behalf of Patrizia Mattiucci, the Clinical Relation Manager, for inviting me and for letting me share my experience with you guys. So the title of the webinar is Minimally Invasive Surgery, the Management of Teeth Extraction from Simple to Complex Cases. But before I start with my topic, I would like to introduce myself. I'm actually a founding and active member of the Italian Academy of Osseointegration. I am the vice president of the International Piezoelectric Surgery Academy, and I actually work at Humanitas Research Hospital in an oral surgery department. Well, I actually come from Italy, but the city in exact place is Milan. Maybe many of you know it. This is one of our typical and ancient buildings. It's the Duomo of Milan. It's a cathedral, very important in Milan. But maybe many of you know us for our two football teams, the AC Milan and the FC Internazionale. Personally, I support the FC Internazionale. Another very important thing for me is my family. I would like to introduce you to Tommaso, Ludovica, myself, my wife, which gives me a lot of support, Michela, and my elder son, Nicolò. Another important part of my life is my working team in my office. And this is one of the relaxing moments with them in the summertime. And a third party, very important, which represents the future of my oral surgery, is my oral surgery team in the Humanitas Research Hospital Dental Center. And they help me a lot to produce the material I'm going to show you. So let's start saying that what we know is that patients are different. So we have to take in mind, by looking at this very nice video animation, is that patients are different and we don't have to consider them all the same because everyone has a different characteristics. And for example, young children have a bone base which is different from an adult bone base. And what we know is that actually we want to know what and where we are working on to know what we have to do. And to do this, we have to consider life. Life is a very nice thing. Life is maybe represented in this picture as a white star color, but we know that white is made out of different colors. So what we see in reality is not always what we are looking at, but is made of different things. So what are we going to look at today in the matter of extractions is that we have to look at three things: diagnosis, experience, and technology. Knowledge and diagnosis are something very important to bear in mind when we have to perform surgery on our patients. Technology is another issue that is very important, and we have to know what the market and what the industries are working on to make us work better and maybe achieve better results. But most of all, our experience and our learning curve is very important because obviously a postgrad student and an experienced surgeon will have a different place on the learning curve. And this is very important to assess and to program the surgical moment. So if we blend these three things together, we're going to have a good practice. So we were saying knowledge and diagnosis, very, very important things. We have to know a lot of the medical issues of our patients, and we also have to use the technology that is in our possess to let let and see exactly what we are looking at. Take this example of a simple reconstruction of a CBCT that shows us very interesting things. This is the area where the nerve is passing and tells us that there isn't a real contact between the roots of this supplementary wisdom tooth. It's a ninth tooth. But another important thing is that if we look at that small hole that you saw on the mandible, well, that represents a small bony artery that can result with a complication or a problem during the surgery. So the fact that we can see them before we start the surgery, I think that it's a very good and interesting thing to do. What I tend to say to postgrad students and also to my patients is that what I would like to do is I would like to make my surgery on a table without having the patient, so to test and try to imagine what the surgery is going to be before I perform it on my patient. And then we have to take in mind the healing and mechanisms. And these are 5 phases that we are going to have in front of us after we do our extraction. And we have the hemostasis phase, the granulation tissue, the osteoconduction phase, the new bone formation, and the modeling and the remodeling. And we have to know that obviously everything depends on some differences. Like we said, that if we have a patient that is assuming anticoagulant medications, then we will have a particular and difficult hemostasis. And if we have a patient that is suffering from diabetes, well, he will have a slower healing time. And this is also true maybe for elderly patients. Where can we give our support? Well, we can give our support with applying a minimally invasive surgery, so reducing the quantity of bone that is removed to perform the extraction, and to be as gentle and as light on the tissues in order to make them heal better. Blood is essential for proper healing, and this is something I learned many years ago back in 1996 when I graduated in dentistry, and my thesis was exactly on bone healing of big cystic cavities without filling them with materials. And I demonstrated with my thesis that it was possible to have some good and proper healing just with the blood that had to fill the bone cavity and then create all the patterns that we see for a good healing. An interesting thing that we saw during our lectures and our growth in the International Piezoelectric Surgery Academy is this classification proposed by Professor Tommaso Vercellotti on the types of extraction, but we will go in detail on this. We have four anatomical classifications depending on the biotype and depending on the ligament. So for the gingival biotype, we know that in thin biotypes, a soft tissue graft maybe is required, but we can also act on the surgery we perform to reduce the successive shrinkage of the soft tissues. And with thick biotypes, we should expect more soft tissue stability after tooth extraction. So let's take a look at type number 1. It's quite easy stuff. It's a normal ligament, it's a normal periodontal biotype. So what do we have to do? Well, we have this patient. Usually when I have these teeth that present some cavities, some decay, I always tend to make an incision in the sulcus to go and see where the bone is and to be as minimally invasive as possible. Whereas if I used a forceps, I wouldn't know what I was going to do under the gum. And if we look closely, we see that we place our lever. This is going to be a particular lever I will show you in a moment. And then with the root picker, I am able to pick up my extracted root and then place a collagen sponge, a suture, and finish my surgery. But if we have a look closely on what this extraction I just performed, you will see that this lever is a particular lever and it's a dual edge lever. I have a copy here so that you can maybe see the point of this lever, and this is quite interesting because the small and pointed part actually penetrates the area of the ligament, and then this is followed by a larger area which actually pushes the root outside of the alveolus. And then with a root picker we can get our root, extracted root, and take it out of the mouth. So good tech means also good practice. And this is another simple case, type 1. This patient has a fracture of a canine. It's a vertical root fracture that we see. We elevate a flap because we know by probing the gum that we're going to have a bone adhesions. And so after we elevated our flap, we see the fracture and we can apply something a little bit less invasive than the lever I showed you. And this is a very fine pointed lever that actually enters the area without removing any bone. And this, with a minimally invasive blade, gives us the possibility to have a luxation of the area and then to perform and finish our extraction. And this is what the post-extraction looks like. And now we are able to perform a regenerative procedure. This is the moment where we do the releasing of the flap to reduce the tension so that we close for primary intention after our regeneration procedure. But what happens when we have a normal ligament but a thin periodontal biotype? Like in this case, this tooth has a big decay and it needs extraction. What we see is that we don't have a lot of keratinized gingiva and gum, but we have a good area of bone in between the roots. So what we decided to do is to perform a minimally invasive surgery with an incision of the sulcus with no flap opening. And then once we removed the tooth, in this case with piezoelectric instrumentation and the lever I showed you before, we are able to go and prepare minimally invasively the area of the bone in between the roots, enlarge this space, and insert our implants. After that, we're going to do some closure of the gaps on the sides with some bone substitute and collagen, and close our flap with two simple stitches. And this is the appearance of what we see after the healing period. A very nice and healthy gum that is ready to receive the temporary and then the definitive crown. And this is an x-ray of the result after a period of time. What happens when the game becomes a little bit more difficult? So we are in type 3 and we have an ankylosing ligament but a normal periodontal biotype. This is the case, for example, of young patients that have ankylosis of their baby teeth, of their deciduous teeth, and that are unerupted. So they're under occlusion, but they need extraction in order to make the permanent teeth erupt safely and in the correct position. And so in these cases, we elevate a flap, we open a flap, and we use the ultrasonic piezoelectric device to create the space and cut the ligament, cut the ankylosed area, going to place the axis of our instrumentation towards the tooth and not towards the bone. So we want to preserve the bone in order to perform our extraction. And these are moments of the extraction, and this is the end of our extraction. Another case, left lower deciduous baby tooth in ankylosis. This has induced the permanent second premolar to deviate towards the first molar. The orthodontist asked us to remove both the baby tooth and the permanent tooth. So this is a very, I believe, interesting image, because you can see here, you see the stamps of the root as to show that the thickness of that bony area is very, very thin. So we have to be minimally invasive to reduce the post-op possible complications after this extraction. And so we cut the ankylosis with a piezoelectric blade, we cut the tooth, we separate the roots, we extract the roots, and then finally we can have access to the permanent tooth that has to be extracted for orthodontic purposes. But then when the game becomes even more difficult, so we are in the worst scenario, we have an ankylosing ligament and a thin periodontal biotype. And this procedure was presented by Tommaso Vercellotti in about 2010, 2011. And it is very interesting because it recalls the new moment of implant surgery of the buccal wall preserving area, so the socket shield in the insertion of the implants. But this was done ways before, and it was used to remove the buccal shield of the root in the ankylosed area. So this is one of his first cases. It's a first left incisor that had to be extracted for a fracture. And what we see when we open the flap is that there is no area of the ligament. So we go and separate vertically our root, keeping the buccal part of the root on the side without touching it. We extract the palatal part, and then we access the buccal part of the root. And if you see, the insert is directed towards the root and not towards the bone. And this gives us the possibility to remove the external buccal part of the root and then perform like in this case, our post-extraction implant placement. And this is another example where we cut the tooth, we keep the buccal side, the buccal area of the tooth in place, and then we remove it, as we did in the other case, pushing it towards the palatal aspect, towards the lingual aspect, and this gives us the possibility to maintain this very thin area of bone that is very important to the healing of our bone in order to place an implant in a second moment. But let's talk a little bit also about wisdom teeth. Well, on wisdom teeth, we know many things, and we know that the classification that we had since 2017 was the Pellen-Gregory and classification. But this was a very old classification that just gave us an idea of the position of the tooth. So this is how we perform our surgery. Is a simple case. In this case, we had to extract both the element 3.8 and the element 3.7 because this is a patient that has had some cardiac surgery, so some surgery on his heart, and couldn't have any kinds of infection. So the idea and the meeting with the periodontologist was to define if we could save this tooth that had a very deep probing on the mesial aspect and a very big cavity on the distal aspect. And we decided in a multidisciplinary meeting to extract both teeth. And so if we go on, we see that we perform the probing on the seventh tooth that shows us that there is a non-healthy area of our seventh tooth, the distal probing, and then we perform an incision, which is a sulcular incision with a distal releasing incision. We open our flap, and what we see here is a luxator lever forte, which is very useful in these cases where we have to do an odontotomy, which is a partial cut of the tooth that has not to be completed in order to avoid any complications on the lingual aspect, on the presence of the lingual nerve. And so we complete this kind of section with the lever, fracturing the tooth, but we will see that later in a video. And then once we remove the crown that was impacting against the seventh tooth, we are able to extract the second molar and then go on with the extractions of the roots of the tooth. And this is where we separate the root and we remove them separately as two singular entities. And these are particulars of our extraction pieces. This is a particular aspect, very important, where we have to clean and wash our post-extraction area and a primary closure of our flap. This is Giovanni on the other side, because we performed surgery also on tooth number 4.8 and 4.7, which had a major caries decay on the second molar, and we had to extract the tooth. And we see that the procedure is pretty much similar. We tried to make an ergonomic surgery, so our surgery tend to look always the same. So we do an incomplete odontotomy and an incomplete coronal cut that we complete with a luxator forte, and then we separate the roots and we remove them separately in order to reduce the amount of bone that we have to remove. And this is a particular image of the extracted teeth. But when should we take a CBCT? When should we take an image of a second level image? Because the gold standard in the first diagnosis is the orthopanoramic radiograph. But Megawa and other authors have shown us when we have to perform and take a CBCT. And this is when the mandibular canal has a deviation, or when there is a radiolucency of the third molar roots, or where there is a root narrowing image, or where the white cortical layers of the canal are missing, and so this shows us that there can be a contact. But I would like to bring to your attention, and if you want, you can take a picture of this QR code so that you can have the abstract of this paper by Claudio Stacchi, who is actually the president of the International Piezoelectric Surgery Academy, and he published a classification for assessing surgical difficulty in the extraction of mandibular impacted third molars, description and clinical validation. Actually, he proposed a modification of Jubalas and Daugela classification, which was already a new classification that followed a little bit of Pell-Gregory classification. But what is the help, what is the aid of this classification? Well, it is very interesting because this gives us an assessment. It can assess the difficulty of the case that we have to do. So this, compared with our learning curve and our experience, can give us a hint and can give us a help on whether to start or not the surgery or to send it to a more experienced surgeon. And so we have some assessment numbers: 0 for conventional, 1 for easy, 2 for moderate, and 3 for hard and difficult. And we take a look at different parameters. Some of them are obviously on the basis of the Pell-Gregory classification. And I have to say that to do this classification, we have to have a CBCT. So it means that this kind of wisdom tooth surgery is going to be a difficult surgery. So we look at very quickly, we have the relationship with the second molar, and we have different assessment numbers. The relationship between the mandibular ramus, and this have different numbers. The coronoapical relationship with the bone crest. The relationship with the alveolar nerve, so if it's more than 3 millimeters from the inferior alveolar nerve, if it's contiguous, so close with the alveolar nerve, but the canal walls are still recognizable, if there is no area recognizable between the tooth and our canal, or if there is an intervadicular area where the nerve passes through the roots. And then there's a relationship, very interesting, between the bony walls. So to see where the tooth is placed, if it's more vestibular, buccal, if it's more lingual, or if it's centered. And this gives us a further information. And then we have the classical aspect on the spatial relationship. So if it's vertical, mesioangular, distoangular, or horizontal, or inverted. So this gives us an assessment of the surgical toughness of our surgery that we will perform. And we know that if it goes from 0 to 6 points, it's going to be an easy surgery. If it goes from 7 to 12 points, it's going to be a moderate surgery. And if it's from 13 to 18, it's going to be a difficult surgery. So if we look at Roberta and her case, we have a 4.8 wisdom tooth. This is a particular of the paraxial image of the CBCT, and this is a reconstruction of the tooth. And we have M1 parameter, R1 parameter, so easy parameters, A2 a little bit more difficult, C2, and this is the relationship between the canal, the nerve, and our roots. A B3 is the spatial area, and an S, which shows us that the tooth is horizontal. And so this has a classification of 12. It's moderate, so it's a class 2. So it's an intermediate wisdom tooth. If we look at the surgery, we will see that we have an standardized surgery. We usually tend not to go further than the seventh tooth, we have a crestal sulcular incision, a distal release incision, a full thickness flap elevation. Then we have the partial coronal fracture. This is to show you how we perform the partial coronal fracture, and then we separate the roots, always with an incomplete separation. And then this is the particular of the extraction, a primary closure of the wound. And then in the majority of the cases, we perform an injection with dexamethasone 4 milligrams intramuscular to reduce the postoperative edema. This is another case, the 3.8. It's a little bit easier. It's mesial-angulated, but it's quite superficial. There is a small contact with the nerve. This is the spatial area in between the lingual and the vestibular aspect, and this is the inclination towards the mesial aspect. Total score of 8, so just above the easy extractions, but still in a moderate case. And this is a particular PowerPoint of how we perform the extraction. So we perform our incision, we perform our flap elevation, we manage to reduce the amount of elevation that we did. We separate the tooth in two because it's a biridiculated tooth, so we separate the tooth in two, and we extract the two coronal root aspects separately. And this is a particular of the extraction of the luxator forte in action, and a particular of the final extraction. But what happens when we have a late diagnosis? So we're talking about diagnosis and knowledge. Well, what happens is that, like in this case, a late diagnosis has taken this adult patient to have a very swollen area just under the nose to arrive at our clinic, and we had to perform a surgery to extract these two impacted teeth that were just under the nose in association with this cyst that had formed around the tooth. So we performed a trapezoidal flap, full thickness flap elevation, the identification of the surgical of the lesion. Then we separate and we open the lesion. Once we open the lesion, we have to suction all the material that is at the inside of this lesion. And now we can look at the two impacted teeth that we have to luxate with a very gentle and delicate way, because we are in a particular anatomical area which is just under the nose, and also because the bone base is reduced because the cyst and the expansion of the cyst had reduced the quantity of bone that we had. So once we do our luxation, we can then grab the tooth with a forceps, but it's just to pick it out of its area. Then we have to cut the canine in parts to extract it and remove it from the apical nasal area towards the coronal tooth area. And this is a moment of the extraction. This is the point when we had removed the teeth and the cyst, and this is when we perform our suture. But how can technology help us? So technology in extraction can help us in two basically different ways. One way is the piezoelectric technology, and we have seen that in the presentation. We know that it is very precise because the vibration of the instrumentation can manage to create a space in between the bone and the tooth without removing this area of bone. And this is very, very interesting and very, very minimally invasive. obviously we need a learning curve, but on the other hand, we also have to change paradigma in terms of levers. And so we will have to use particular, very sharp and effective levers, because we can't use normal levers in this kind of surgery. The other important issue of the piezoelectric cut is the selectivity. So we know that this kind of surgery doesn't cut soft tissues, so we are going to be safe when we're working close to the inferior alveolar nerve or close to any other soft tissue that are around our area of interest. And another important aspect is cavitation. Cavitation is the passage of the saline solution through the vibrating instrument, and this creates an implosion of water and air drops that collapse on the bone, and this stops the bleeding from the bone. And another interesting application of this cavitation is actually the separation effect. Look at this enucleation of a large cyst of the mandible, and we can see how this cavitational effect is used to separate the cystic lesion from the bony without destroying the cyst, so without leaving any residual areas, and also creating a cleansing of the bone cavity. So we create the space for the extraction of the tooth, and then we come to the surgical levers. And so I can suggest that the usage of levers like the luxator forte from the recta or the dual edge can be very interesting because they have some special characteristics. We have a longer shank that allows a better sight. They also have shorter shanks, which I personally don't use because I prefer to have a better sight from my hands to the tooth. A very interesting aspect is the ergonomic handle, which is this one. And this creates a very interesting grip and firm grip, which gives you the possibility to control the force. And the minimally invasive blades reduce the surgical trauma. But we have to say something interesting and something that has to be taken in mind if we use this kind of levers. They are very sharpened. They have a very efficacy effect, but we have to use them either with a gentle handling of the instrumentation, so with this force and with this movement, or we have to perform a surgery where we are going to have a protection of the area of interest so that we have a double position of the hands in order to stabilize our movements and to avoid the fact that the sharp area can go in the soft tissue. I also suggest to place maybe a cotton gauze on your left finger. For me, it's the right finger because I'm left-handed, in order to prevent any damage of your finger as well. Another possibility is to place the first finger in position to stabilize the moment of the luxation. So this is the protocol I suggest for the minimal invasive surgery extraction, so we can perform a minimum access flap because we are using very sharp and precise instrumentation. We're going to perform an osteoplasty or an osteotomy depending on the thickness of the bone that covers the tooth. We're going to use a straight handpiece to cut the tooth if the tooth is in a normal position. or we're going to use a piezoelectric cut of the tooth if we're working in areas, in anatomical risky areas where we need precision and mini invasive approach, for example, close to the inferior alveolar nerve. And then we will have to use these kind of levers, so luxator forte or the dual edge or any other luxator, which has a very wide variety of different levers depending on your choice, depending on what you prefer to use. I personally showed you what I use, and then a suturing of our wounds. As we said, the experience and learning curve is very important, but with a correct diagnosis and assessment of what we're going to do, we can then start and approach much more difficult cases, such as this case where we have three pathologies all mixed together. We have a wisdom tooth, we have a radiolucent lesion, and we have a radio-opaque lesion. But the important thing, as I told you, is the diagnosis. So the initial assessment of the case. And what do we see? Well, if we look carefully at our CT, we see the area where the nerve enters the mandible, and then we see that the radio opaque lesion was held in place by two bony isthmus that kept the lesion in place. And another interesting thing is that the position of the tooth, which is in this area, shows that the nerve is buccally respect to the tooth, and so we know that we can't drill and we can't use too much bone consumption on the buccal side because we will going to find the nerve. Once we assessed our diagnosis, then we perform our surgery, a pre-op view, then we just enlarge a little bit our incision and flap because we want to see better because there is a major lesion that we have to remove. The initial phase of ostectomy to remove the surrounding bone. Then we start to cut the osteoma. But if you look closely to the cut on the osteoma, which is performed with a piezoelectric chisel, we can understand that just a very sharp point of a lever can go in that small cut. Then we widen the cuts to remove the the radio-opaque lesion. And once we remove the radio-opaque lesion, we can start to perform the extraction, going to cut the tooth, which has been done with a regular straight bar on a straight handpiece under constant saline solution irrigation. And then we remove further parts of the tooth, we fracture the tooth, and we start luxating the tooth from its position. Once we remove the tooth, and these are the fragments of the removed tooth, then we can start to work on the cystic lesion. These are particular phases of the enucleation once the cyst has been enucleated, and this is the moment where we see the entrance of the inferior alveolar nerve in the shower, and then we knew that the nerve passed from the lingual aspect towards the buccal aspect in front of our wisdom tooth. And then, as I showed you in my degree thesis, we just place a collagen sponge to stabilize the blood clot, and we close for primary intention, and this is the 1 week recall. Now I would like to show you a short video which shows us very clearly how we perform the surgery of a simple wisdom tooth. But we have seen the clinical images But with this video, everything will be a little bit clearer. So this is the distal releasing incision that is kept fairly distal in order to avoid the risk of lingual nerve damage. This case, we had a temporary crown on the second molar that we will going to remove later. And now we see that the tooth had to be extracted because of different moments of infection. So we can see that the soft tissues are not very nice in the aspect, and we have to look to find the periosteum to use it afterwards as a membrane, because the periosteum is the best membrane for the healing. So we place our Langenbeck to elevate the flap and to make the protection. We see that the fissure bar goes exactly in front of the Langenbeck in order to avoid any burning of the soft tissue. We are now working under saline solution. We are cutting the tooth. I am sorry if the video sometimes stops, but going on the webinar, it's a little bit slower. So we fracture with the luxator our crown. So we perform the fracture with the luxator. We separate the tooth more. We always prefer to separate the tooth in many parts in order to avoid the bone loss. Then with a root picker, we remove the crown, the temporary crown. We remove the pieces of crown that we have previously cut. It is very important to look and not to lose any fragments, which could be the cause of a secondary infection. With the root picker, we go and get our coronal fragment, and now we can make the separation of the root aspect. So we perform a buccal separation, which is completed just towards the center of the tooth. We don't go to the lingual aspect. I'm stressing the point on this. We create an initial fracture to remove and to separate the two roots. We have an initial fracture of a part of the root picker. We create a little bit more space in order to have a major area where we can go and work, and then we continue with our root separation, always working inside the tooth and not outside of the tooth when we're performing the cut. So here we create a little bit more space. Here is the moment where we cut the root, and then once we have cut the root, we can apply a gentle force with our lever, and we see the moment of the fracture. Here we go, and we have the moment of the fracture. So we can now gently move the distal part of the root. We remove the mesial part of the root, and we can extract the tooth from the socket. A particular important moment is the moment where we have to clean the distal part of the second molar in order to remove any particles of granulation or inflammation tissue, which were the causes of the pericoronitis, of the inflammation of the tooth. And this is a Loren-Gottel moment of the suture, or barone modificato. It's a vertical mattress suture so that the tissues can close just very well behind the second molar, and a closure of the tooth, of the wound, and of our flap. So we can go on, and just a second that we go on with the I have a problem with a slide. Let me see. Okay, if you can give me, no, it's back one slide. Okay, so we were saying that, just a second. Okay, sorry for the delay. As Professor Brannemark told us, nobody should die with their teeth in a glass of water, so we go a little bit back on the implantological aspect of the extractions, and this is to show you one last case of an extraction that had been done for a fracture of a first left central incisor. This is the moment of the flap design. It's a saltular incision. Then we do our flap elevation. We always try to do some flap elevation when we perform the extractions in order to see the bone and in order to protect the bone. We are using the ultrasonic device to create a working area. This working area is a few millimeters. It's just 0.5 millimeters. Luxation, gentle luxation, and the forceps just to remove the tooth. And then all the things that you know better than me, palatal aspect of the preparation of our implant placement on the palatal side, and this is the preparation of the implant side preparation with the surgical burrs, enlargement of the hole, keeping in mind the axis, implant insertion. We see that it has a palatal aspect insertion. We check the torque insertion so that we know if we can perform a post extraction and primary insertion of the crown. In this case, we perform a delayed temporarization, so we placed a crown, a temporary crown that was fixed on the adjacent teeth using an orthodontic appliance. And then this is the moment of the suture to show you the minimal invasive extraction. And this is a follow-up, a 2-year follow-up of the crown in place, the implant inserted. So with this, I would like to thank you for your attention, and I would like to share with you this nice sentence that goes, "Don't turn back, we have already been there." This is my email if you need any advice, if you need any extra information about this webinar, and now I'm here for you for any questions. Thank you very much. Just tell me from the manager desk if so. Okay, they are asking me if I have any experience with the mallet. Personally, I don't have experience with the magnetic mallet. I know how it works. I actually used it a couple of times to do small crestal sinus lift approaches. I don't have any experience on the basis of the extraction, but I believe that the mechanical pumping of the magnetic mallet can be useful to perform a minimally invasive space in between the tooth and the bone in order to reduce the bone consumption, because obviously the aim and the mission of our minimally invasive extraction is to reduce the bone that we are removing to make our extraction. So I believe that it can be a possibility, a technological possible instrument to use, but I don't have any personal experience. So what do you do if you have, after extraction, some complication like trauma of the mandibular nerve? So, very interesting question. What I say to my patients is that if there is a real connection between the root and the nerve, and this we can see it in the phase of diagnosis, then what I know and what I tell them is that I am sure that I'm not going to cut the nerve, but nobody can't um, give 100% for sure that there is not going to be any trauma simply by the fact that when we extract the tooth, we create a slight irritation of the peripheral area of the nerve. So, if I have any idea or I believe that there can be a trauma on the nerve, I usually give a corticosteroid therapy to the patient for 3 days, and I also give them a neurotropic medication to enhance the conduction, the impulse conduction of the nerve. What we have to do is we have to very precisely assess in the first moments, so after a couple of days or 3 days, the entity of the nerve damage or actually the symptoms, the effects of the nerve damage. So we have to map where we have the paresthesia or the dysesthesia or the anesthesia of the area in order to check in time and control if there is a better phase of healing in time. And this is an interesting thing to know, to see if there is going to be a moment of complete regression of this problem. I hope I answered your question. Another question is, any difference between sonosurgery and ultrasonic surgery? Are they interchangeable? Nice question. I know that there are many appliances, many technical devices. Personally, I only tried a couple of them, but I spoke with other colleagues who tell me that the sonosurgery instrumentation is good in performing some types of surgery. So it can be absolutely a possible thing to have in exchange. Okay, you want to tell me if there are any further questions, or we can conclude our webinar connection. Okay, this is a thank you, and I thank you, Gwen, for your message. Okay, so you just send me another message like this when you want to end the connection. I am here for you for any other question or issue. So, I would like to thank you very much. I would like to thank Dental Tribune for their technical support, and the Direct Dental Group for their kind invitation, and all of you who have participated to this webinar. So thank you very much and have a good day.